We're going to talk about the usual progression for chest pain. So, and it's unfortunate because, as you will see, it's not that well documented in terms of science. The basic groups like Choosing Wisely, the board.
Sorry to cut you off. You might want to share your presentation.
It's not being shared.
It's not. We're just seeing your YouTube.
How about that? Is that sharing?
No.
I don't know what else. Well, let's try this.
Yep, there you go.
Is that sharing?
Yes.
Okay. Thanks again, guys. At some point, we will get there. You would think that we hadn't practiced this. We've put probably about 10 hours into making this work. And again, I used to feel like an idiot trying to get this YouTube live to work until I've seen recently some much larger, more experienced channels have similar problems. Anyhow, back to the topic. It's unfortunate that that management of chest pain is where it is today. Most of the steps are just not that well founded in terms of evidence and science. Now, I'll go through some basics, and we've mentioned them before, which may irritate a few people who've been through some of this experience. Again, please just remember, I'm reporting the science, I'm reporting what's in the evidence. And as you may or may not know, I'm also reporting what folks in the medical standards groups like the American College of Cardiology, boards of internal medicine, family medicine, and social interest groups such as Choosing Wisely have all said. In addition, the science, I'll show a couple of the science articles that support this as well. So again, it gets to the point, back to the point, I'll go ahead and give a spoiler for that, and that is heart attack, stroke, all of these things are things that we want to prevent. We don't want to start getting involved in having chest pain and going down that path. So the first thing that happens with chest pain is you go in to see your doc tends to say, okay, well, let's do a stress test. Well, when you think about it, you're going to get a positive or a negative stress test. And that's about as deep as most people think. Actually, the next thing you should be thinking is if it's positive, that could be true or false. If it's negative, that could be true or false. So if it's negative and it's true, that's a good thing. But if it's negative and it's a false negative, that's what happened with Tim Russert. And as we know, he died three months after having a negative stress test, a normal negative stress test. So you're better off having a false positive than a false negative, but a false positive is not that great either. A false positive stress test usually takes you to the cath lab. And once you get in the cath lab, what happens next? You're usually going to see at least some blockage. Hopefully you can still see this. You get in the cath lab and quite often you end up with a stent. The stents work if it was a heart attack, and it was a heart attack that is treatable by a stent. But the bottom line is that 90% of stents are not given in that situation. 90% of stents are given for other reasons, like preventing a heart attack. The Courage trial showed that that doesn't work. To cure angina, and the Orbita trial showed that that doesn't work. And there are plenty of other trials in both of those categories. And again, the fourth indication for a stent is just plain old, it was blocked. So I put a stent in there. And again, if it was blocked and I put a stent in there, that means you think you're going to prevent an event. So is this Brewer just being a wild internet doc? No, we've covered a lot of this already. As I mentioned, you see it with the boards of internal medicine, the colleges of cardiology, my groups, the College of Preventive Medicine. You even see it with the lay press. This is a more recent one from New York Times. Heart stents are useless for most stable patients. They're still widely used. Now, again, I said this may irritate some people. I know we got some comments in the past when we've covered some of this, and people have said, I had a stent, it helped. Nobody's saying that that never happened. What we're reporting on, though, is the publications, the scientific evidence. Here's one also from the New York Times a year or so earlier than that. Again, something that these came out and they surprised the experts because everybody thought it's got to be helping. So this is the COURAGE trial that I mentioned from the New England Journal of Medicine. As you see from this era right here, that was the COURAGE trial investigators. Basically what they did was they looked at people that had stents and looked to see, did the stents actually prevent heart attack? The bottom line was there was no evidence that they did. Again, big surprise. That came out, what, 4 years ago. More recently, just a couple of years ago, or last year, January 2018, Lancet, one of the top journals in the UK, came out and said, well, okay, so it doesn't work in terms of preventing heart attacks. How about maybe it prevents angina, or maybe it cures angina? And as you see in the title here, this was intervention in stable angina. This was a study that I've mentioned a couple of times before. It's a study that probably never would be done in the US just because of human subjects review boards and ethics review boards. They actually took these patients and completely blinded them to whether or not they had a stent. And how would you do that? They took them to the cath lab. They prepped them for surgery. They did the cath, but they didn't do the stent. And again, that's not something you can imagine happening in the US. What was surprising to many people was, at the end of the day, the group that had the stent did not do any better than the group that didn't have a stent in terms of their progression of angina or their cure of angina. So again, that takes us back to my original comments that it's unfortunate, but that's the usual progression in terms of taking care of chest pain these days. You go into the doc says, let's do a stress test. You may get a 30% likelihood if you get a positive that's false. That takes you to the cath lab, but that's a heck of a lot better than getting a false negative and having an event. Once you get into the cath lab, very high probability of getting a stent. And again, not a lot of evidence that these interventions work. So just a couple of other points, and I'll wrap that up and go back out to comments. These came out of the New York Times articles in very plain English. The devices, meaning stents, are life-saving when used to open arteries in patients in the throes of a heart attack, but they're most often used in patients who have a blocked artery and chest pain that occurs, for example, walking up a hill or going upstairs. Sometimes patients get stents when they have no pain at all, just blockage. And again, that comes under the category of, if you're a hammer, everything looks like a nail. So heart disease is a big issue. It's still killing, 800,000 people a year. 800,000 people have a heart attack. Half of those die immediately. Stenting's a mainstay of treatment in virtually every hospital. More than 500,000 patients worldwide have stents inserted each year just for chest pain. Other estimates would say that's far higher. Obviously, this research was not done by Boston Scientific, Medtronic, Abbott Laboratories, other groups that are that are making 11 to 40,000 each time one of these is done. I don't say that to implicate big pharma or the medical industrial complex. It's just that once we start going down that treatment route, we are in you're in a world of hurt if you're the patient. So let's go back. Let's think about prevention. I believe that covers the major items that I wanted to cover for just getting us started tonight. As you see, the world of medicine changes a lot, changes very quickly, changes every day. And that's actually the purpose of something like our Louisville event. You can call, we've got Clyde actually, who's helping me, who helped me get this set up, is helping us with our technology. Clyde is setting up a call center for us. I've got the number down there, 859-721-1414, extension 3. You can also get Michelle on extension 2. And just another word or two about the Louisville event, and then we'll start taking questions. The Louisville event is right now a 2-day event where you don't have to worry about where to get your labs done. You don't have to worry about where to find the CIMT. You can get it all done right there. And then instead of spending like an hour with me reviewing that, we spend 2 full days going over details. And people that are, this is not for everybody. This is for people that are willing and interested in investing significant dollars and significant time in learning how to prevent their heart attack or stroke. I believe I have gotten into another of a tech glitch here and started to get at least visually into a video loop. If you'll be patient for just a second, you'll see hopefully that call center telephone number coming up. There you go. So thank you for your interest, for your patience. I see several. Thanks, Rob, Paula, Bart, Simra, James, Jim, for coming on. And yes, we did realize we were having a audio problem. Evidently, that problem has not come back. Hopefully you can hear me at this point. Simon Troe from Liverpool. Simra, I shared. Paul Harrington, I can see it. You're doing great. Thank you, David. Paula Jackson, that's what happened to my dad, heart attack 2 months later. Paula, so are you saying he went in and had a stent and had a heart attack, or a stress test and a heart attack, or what? I'm sorry to hear that. Noor Rani, my dad had a stroke 7 days ago. Again, if you just look at our country alone, the US, we went through a long and bitter war in Vietnam, and it tore the country up, as well as obviously tearing other countries up even worse. We are losing from heart attack and stroke every 3 weeks, I believe. Somebody correct me on that and fact check me. But I believe it's every 3 weeks. And I believe the number is something like 50,000. It's just a huge number. And here we see, just out of a small audience tonight, we've got 2 people, both of whom have a near family member who have suffered from one of these conditions, heart attack and stroke. Okay, Paul Harrington, is it better to get a coronary artery calcium score than have a stress test? Yes, Paul, in many ways it is. What we want to do is see if you have plaque. Coronary artery calcium score tells you if you have a positive calcium score, it says, look, you've got plaque in the arteries of your heart. Now, unfortunately, it doesn't tell you the next thing, which is very critical, and that is that plaque soft? Is it inflamed? Is it liquid plaque? Because calcified plaque is not going to break off, form a clot, and cause a heart attack or stroke. Only the soft liquid plaque well. And that's why you've heard us talk many times about CIMT, carotid intima media thickness test. You can find out whether that plaque is actually soft, inflamed, unstable, ready to cause a clot with CIMT. Now, so it sounds like, well, CIMT must be the best thing to do. It is, but just like everything else, there's a problem with CIMT. Number one, it's very dependent upon the technique of the CIMT technologist or technician. Number two, because of that, it hasn't been pushed that hard in standards. It will be as it continues to grow in effectiveness and standardization. And because of those two things, it's very difficult to find one. Now, you say very difficult to find one. The reality is I've worked with 3 or 4 providers throughout the country. I know that there's one provider that does a very, very good job, and he's all over the country now. It just sometimes takes him time to get a technologist out. So that's why I brought up that you can go to the Louisville event. We're going to have a technologist there doing CIMTs. So you get the labs, you get the CIMT, and you get the boot camp type of experience where you learn, okay, this is how to interpret each one of those 30 to 50 labs. This is how to how acute my issue is. These are the things that I need to be doing to fix that. And this is how I prevent that heart attack or stroke rather than trying to deal with it after the fact. So we've got Loretta Dillingham. Good morning. And Loretta, you're in Brisbane, sunny Brisbane. And thank you again for the reminder. I don't know why. I guess it's because I've never been there. I keep thinking you're in New Zealand, but then I remember, no, it's Australia, but I just don't remember which town. Thanks for reminding us. 147 degrees west in Alaska. Do you have the link to the video on the secret life of fat cells? That link should be, thank you for asking. And I did realize I forgot to put that link in there, and I put that in there today. Or if you'll go back and look at that video, I will just confirm that it's in there. The Secret Life of Fat Cells is if you haven't seen it yet, I didn't do the video justice. It was done by a fellow, I'm blanking on his name now. And here we go. Philippe, gosh, I'm sorry, I'm not seeing it. Oh, okay, yes, Dr. Philippe Scherer. And I did, if you go to 147 degrees west, if you go to the video that I did on the secret life of fat cells, if you go under about this video, you'll see a link now. And that link is to the video that we're discussing. For the rest of you, basically, this is an excellent video from one of the Banting lecturers. He actually won what's called the Triple Crown in diabetes research. One of the items in the Triple Crown is called the Banting Lecture, which is like a lifetime award for presenting good research in diabetes. What Philippe Scherer at UTSW has done is done a lot of the work associated with helping us understand that we used to think fat cells were just a repository for fat. They were not very active. They didn't have a lot to do with anything other than storing fat and storing energy. Now, over the past decade, we've found that's not at all the case. Fat cells are actually endocrine type of cells. They release things like leptins, adipokines. I'm sorry, I've been talking all day trying to get the tech set up for this. The fat cells, when they're unhealthy, cause things like insulin resistance, and they do a lot of that by the endocrine activities that they have. James Cantor, how UCB, not understanding that. How much vitiating K2 do you recommend with D3? I don't know the dosage. I will tell you, I have gone back to K2. K2 is a big, it's an interesting topic for a lot of people. I promised a series on K2 about a month ago. We just found that I actually recorded it 6 weeks ago, and it got hidden and it got lost for a while. We found them this week. There's about 3 other videos on K2 coming out. The short story on the science behind K2, there still is no randomized clinical trials which give you a hands down, yes, you got to use it. But there's some very compelling research which actually links K2 to something called osteocalcin, which does in fact help control where calcium is laid down. So it theoretically does help in terms of taking calcium out of arteries, and does help in terms of laying down calcium in bone. What is interesting is there's a significant connection between osteocalcin and insulin resistance. So is it aging or ailing fat cells? Is it osteocalcin? What else is it? I think we're getting to the edges of what's known and what's not. So Simon Troe, if I went to New York for a week vacation from the UK, could I pop into any medical center and ask for a coronary artery calcium scan? Yes, you can find a coronary artery calcium scan usually within 3 or 4 miles of any, you can probably find 200 or 300 in the New York area alone. I know that I've got several patients that have had CIMTs in the New York area as well. You just have to schedule them. Rob TO7, if you had a patient who failed a stress test and had a few 90% blockages, you would stent, wouldn't you? What's the alternative? Bypass. Actually, bypass may be a better alternative. I'm not going to get too deep into that whole debate other than to say, again, that's not where you want to be. I've actually had several patients. I will say this, Rob, I've had several patients in that category. And either A, they have a functional need to go ahead with a bypass, or B, they say, okay, am I going to have a stent? Or C, do I leave it alone? And most of my patients, after looking at the science, have ended up altering with going with either A or C, either the bypass or leaving it alone rather than going with a stent. 147 degrees west, husband had 17 strokes, 2 heart attacks, kidney artery blockage, surgeries, open heart, carotid artery cleaning, among those there. Yet they still want him to eat carbs. Wow, amazing. Paul Harrington, I'm in Sydney, unfortunately, where it seems harder to get this sort of testing and to find someone to help you on this path. Well, Paul, I would let you know, I've got patients in Australia, New Zealand, Israel, Brazil. Richard Lund, Secret Life of Fat Cells. Search for UTSW presidential lecture on YouTube. Yes, that's one way to find it. And you can also find it now under my description. 147 degrees west. Okay, thank you for the link. Want to watch it right away, I believe. Now I've lost the comment. Watch it tonight. Richard Lund, Philippe Scherer, that's correct. Simon Troe, does drinking lots of beer always cause high insulin and damage? I haven't seen any cases when it didn't. unfortunately, I always hated beer until until I went to Germany and tried some of the German beers. Then I came back and I thought I'd arrived in heaven because the craft beer industry had hit the US. I really developed a taste for it. Unfortunately, right about that time, I developed insulin resistance, and I've had to back away from beer. And that's the thing. Most of us, especially by the time we're age 60, are starting to get insulin resistance. Richard Lund, I have my How to Make Natto video almost ready. Next week, K2. Thanks, Richard. 147 degrees west, I take K2 for bones. Simra Bachivan, I do have vascular retinal occlusion. Every 2 months, a Vastine injection I'm receiving. I suffered a TIA cerebral, transient ischemic attack. Also, at age of 36, Simra, you evidently have something else going on too in terms of significant risk factors other than just age. Thank you for sharing that. James Cantor, I can say I do a good report on reduced gum inflammation while taking vitamin K2 this week. Well, good for you. Gums are a big, big issue. We're talking about having some more information about gums available soon. Paula Jackson, what kind of K2? MK7. 147 degrees west. If you want a CAC, Ivor Cummins has links to clinics worldwide with contact information. He's at the Fat Emperor. That's a YouTube channel. And again, yes, you can find, I would be amazed if you cannot find coronary artery calcium score in the UK as well. I appreciate you bringing that up. I don't think the US is the only place where you're going to get CIMT. I mean, where you're going to get a calcium scan. So it is what, 6:30. I'm seeing, it looks like we've gone through the majority of the comments. Unless somebody else has anything specific and burning, I will, here we got a couple of things. Regarding my question about the 90% blockage patient, this is from Rob T07. It happened to a casual acquaintance. A 49-year-old male appeared visually to be in good shape. They stented him. And Rob, just so you know this happens all the time. And I've had patients that have made decisions to go ahead and get stents. I have some concern just ethically in terms of presenting that science, because on the one hand, patients get in that position and they start to feel like, I've got no other options, just like what you're talking about with your friend. After you think about the ethics, do you want people to not know, or do you want them to have the information? And I've elected to say, okay, let's at least make the information available. Bjorn to Fly, if you want to know what bear does to you, best, I think you mean beer, best to look at a world championship in darts. Everyone is obese. Good point, very good point. I think that's the biggest, I would let you know, the, excuse me, I'm sorry about the way too much talking today. I'm sorry. From a physician's perspective, we used to say alcohol is great for your HDL because it increases HDL just a little bit. Unfortunately, once you start looking at the long-term data, the more epidemiological data, alcohol, although it may help with HDL, it doesn't tend to help overall. And because it's, number one, it's got a lot of behavioral issues, but number two, one of those big behavioral issues is eating more. I know that if I have a glass of wine, certainly if I have more than one glass of wine, I tend to eat a lot more. And beer is far, far worse because you can have dry wines with little to no carbs, 2 to 3 carbs per glass. You can have, they actually do make some beers with that few carbs, but not very many. And most people say, and I agree, those beers taste like water. Simon Troe, my diet is fish, vegetables, meat, and olive oil, and butter, grass-fed. Am I on the right track? I think you are. So again, the biggest issue, and I jog 4 times a week. Yes, those are all good, but I drink beer. Simon, you know, you did a lot of damage to all those other good things you were doing by adding the beer to it. So 147 degrees west. How is the pitavastatin going? I went ahead, bit the bullet, and took the pitavastatin that I put on the event a couple of weeks ago. I haven't grown a third eye or horns or anything yet, but I haven't gotten any new labs either. I'm going to get my new labs when I go to the Louisville event, and we'll just see. Kelly C, do you see a correlation? But let me just make one other comment. As a physician who focuses entirely on prevention of heart attack and stroke, excuse me, on the beer question, that is what I tend to see. Clearly with beer more than any of the other alcohols, but mostly with the other alcohols as well. It is so difficult to drink moderately and keep your BMI down. So it sounds like I doubled up on my Ramipril today, haha. So Bill Clifford is making a point that I'm coughing so much. What he knows, some other people know, especially those that have seen my channel, is if I get to a point where I'm talking too much, or especially if we have allergies or allergens, especially if it's allergy season, I will start coughing and get some problems. ACE inhibitors are great for helping prevent heart attack and stroke, especially among people like myself who have insulin resistance. But the same things that help them decrease risk for heart attack and stroke can also cause exactly what you're hearing with me tonight, a lot of coughing. And a lot of people just don't put up with it. I'm a cardiovascular risk fanatic, so sometimes I put up with it. And again, Simon or Bill, I just way too much talking today. We went through a lot of effort, especially with Clyde helping us get this the technology set up. Hopefully it'll get stabilized. We won't continue to have the challenges we've had. Rob TO7. Doc, does a CIMT showing liquid plaque always mean you'll have liquid in any plaques in the heart? Or could the heart plaques be more solid? That is a really good question. Thank you, Rob. So, and I hate to give you a muddy answer, but the reality is muddy. The most common cause of inflammation is increasing insulin, increasing cortisol, increasing blood glucose. And carbs can cause that. Cortisol can cause blood glucose, and blood glucose causes insulin. Now, we know that your insulin situation today may not be what it is tomorrow or 2 weeks from now. We know that it goes up and down. So what we're trying to do is just get an idea of where you are at this point. So you can and will get changes in how much inflammation you have as it goes up or down, depending on, if you gain a lot of weight, you start getting more insulin resistant. BMI is one of the most important indicators or drivers of insulin resistance. You gain a few pounds, you start getting more insulin resistant. Your blood sugar goes up. Your blood sugar is going up chronically, your insulin's going up. Blood sugar and insulin go up, inflammation goes up. Now, it sounds like I skipped over your question, but think about the process I just talked about. If your BMI has gone up and your insulin has gone up and your blood sugar has gone up from an average of 90 to 110 on a regular basis, 24/7, did that just happen here in this artery in the neck? No, it happens in every artery. So this is a systemic issue, not a localized issue. You do get localized variation of the amount of plaque, but again, if you're laying down plaque in one artery, you're laying it down in another. If you're inflaming plaque in one artery, you're inflaming a plaque in another, all the others. Okay, Simon T. Rowe, I'm going to quit beer now, and I'll let you know my progress. Well, that's impressive. If I got you to quit beer for your health reasons tonight, this was a success. Rob TO7, we talked about that. 147 degrees west. I was wondering if the pitavastatin had any side effects at the start. Oh, no. I haven't talked to any patients that have had significant pitavastatin side effects. They're much, much gentler than the other statins. That's why they're so expensive. They came up with them and they realized, look, we've got the good side of statins, and yet we're missing major components of the bad side. We don't have as much muscle problems. We don't have as much insulin resistance going down that diabetes highway. And yet they've also shown over the past 6 to 18 months, those statins also do manage inflammation, which again, if they continue to go down this path, we look like we're in a whole new ball game with pitavastatin. Simon T. Rowe, I'm on a 4 milligram doxycycline, but my blood pressure is normal now. Cause of keto. Very well may be, especially if the keto resulted in you losing some weight. Weight is a very important determinant of high blood pressure. Do I stop that? And do they help inflammation like your ramipril? Doxycycline, I'm going to have to look that up, Simon. I'm not familiar with that med. I wish I were. Rob TO7, thank you, Doc. And again, I appreciate the interest. Where are we now? 6:37. We've been going on for about 40 minutes. So unless anybody has anything else critical right now, I'll sign off. I do appreciate your interest and look forward to getting this darn technology stabilized so we don't have so many distractions from the conversation that we're having. It's a very good one. Oh, okay. Doxycycline's alpha blocker. The alpha blockers and the beta blockers tend not to have that much of a significant impact on inflammation. Some of the beta blockers, Simon, can actually result in some increase of inflammation. So if you can, you would certainly encourage ACE inhibitors first. ARBs, angiotensin receptor blockers, have some improvement, but they're not as well documented to create improvement in the in cardiovascular inflammation space. Beta blockers are, if anything, bad. Now, alpha blockers is a slightly different direction. However, there's not significant evidence that alpha blocker is going to help in terms of cardiovascular inflammation. Paula Jackson, thanks. Bill Clifford, is pitavastatin a better statin than rosuvastatin? Price comparison. Yes, pitavastatin does appear to be. It's new. It came out, what, 5 years ago, maybe a little bit more, and it's been prohibitively expensive. Yes, up until the past 6 to 18 months. Well, let's go back 5 years ago, up till like 3 to 5 years ago. You were seeing a lot of use of pravastatin, simvastatin. Those were good meds. Obviously, by far the biggest use was atorvastatin or Lipitor. And atorvastatin or Lipitor doesn't tend to have as much of an impact. Almost all the statins have some impact on inflammation. But atorvastatin doesn't appear to have as much impact on inflammation if you are female or you have insulin resistance. So female automatically knocks out half the population. Insulin resistant actually knocks out the vast majority because it is the majority of cause, the major cause, as in I would estimate 85 to 95% of inflammation. So although Lipitor or atorvastatin was the major statin coming out of the blocks, it was the more money spent on Lipitor than any other drug, any type of drug, any other drug in the history of mankind for a long time. May still hold that record. It still was not as effective as these others that I mentioned. Crestor or rosuvastatin for sure, but also simvastatin, pravastatin. But 5 years ago, Crestor was it had not lost its patent yet. It was it was in the same position that Livalo is in now. Crestor was for most cases, it was better it was a better statin than simvastatin or pravastatin. So we used some things like some of the genetic testing to differentiate whether this was a patient that could take the less expensive simvastatin or pravastatin or needed to go with the more expensive Crestor. Well, 3.5, 4 years ago, Crestor lost its patent. It usually takes about 2 to 3 years after a medication loses its patent to become price competitive. And Crestor has now become price competitive. You can get generic Crestor for, I don't know the numbers right now, but it's, again, very price competitive. Because of that, there was a significant migration away from simvastatin and pravastatin and focusing on rosuvastatin, generic rosuvastatin. Meanwhile, however, in the midst of all of this, the Japanese were developing Livalo or pitavastatin, and it had significant advantages over all of them, including Crestor or rosuvastatin. The big advantage being insulin resistance. Almost all the statins, including rosuvastatin or Crestor, did cause increase in moving people down that insulin resistance diabetes highway. Pitavastatin actually goes the other direction. It is the one statin that actually helps with insulin resistance. So, thank you, Doc. You just answered my Kelly C. You just answered my question too. Inflammation equals plaque. Well, inflammation starts with plaque, and plaque starts with inflammation. Soft plaque equals inflammation. Hard plaque, calcified plaque, is plaque that has become stabilized. So on a practical basis, you usually don't, the goal is, I see so many patients that say, Doc, I want to get rid of all of my plaque. You can do that, but it's unusual. I mean, you go back and look at my videos. I've been able to do it, but it was because I held off. I didn't want to take statins either, and I held off for 3 years on taking statins before I actually agreed to do it. But when I finally bit the bullet, I made some other changes and was able to decrease my plaque burden. So in terms of what equals what, soft plaque equals inflammation. They're the very same thing. You can slow down inflammation, and when you do, that soft plaque begins to calcify and turn into hard plaque, which is stable. Simon Troe, thanks for all the advice, Doc, and your time. Love the channel. John Anderson, I had a AAA abdominal aneurysm, aortic aneurysm 2 years ago. Ended up with stents in 2 arteries and a stent on the AAA. Well, congratulations for living to tell the tale. You know, John, you know this more than most people. Most people, when they hear the term aneurysm, aortic aneurysm, they panic. They think I'm about to blow up. And obviously the answer is no, you're not. We'll typically watch these things for years until you start, excuse me, start to develop some problems there. Bill Clifford, love your channel and appreciate your candid demeanor and common sense way of explaining these technical issues. Makes sense to laymen. Thank you and God bless. Bill, I have to tell you, I greatly appreciate that comment. I have been like a cat on a hot tin roof with this darn technology trying to make, trying to wade through all of these feedback loops and all of this stuff to actually have this conversation. David Jones, I found something new for me. Uh-oh, I lost. Swimming really clamps my blood glucose under 100 for just over 2 days. I see similar with HIIT, but nowhere as good. Actually, working out, muscles working is the same, has the same impact on your blood sugar as insulin. And people that take that, I don't have it on tonight. I often have a little button, my Libre button. People, and I push that a lot. I want people to be able to understand what their blood sugar levels are. One of the things they find out, David, is that, okay, if I take a carb break and I go out and have pizza or beer with my kids, then if I just schedule a walk, I don't have to take a rigorous swim. I don't have to lift weights. I don't have to do HIIT, all of which are very hard to do right after a carb-laden meal. But just doing a simple 20-minute walk tends to cut the top right off of the spike that you would otherwise see with a carb vacation meal like that. 147 degrees west. They had my husband on 80 milligrams Lipitor twice a day for 2 years. It was awful. I finally got the VA to shift him to generic Crestor. A major difference in his health, I bet. Thank you for sharing that. John Anderson, doc now saying a stress test looked bad and want to drag me into the cath lab. I'm looking for a new doc. Thanks for all you do, Dr. Brewer. Thank you for sharing that, John. I know that's you're in a challenging space when you have to be making this kind of decision. I appreciate you sharing what's going on. Loretta Dillingham from Australia. Do you have any words for dealing with the fear of anticipation of the result of a coronary artery calcium score? Well, no, I don't. I'm sorry. I hope this is not your first calcium score, and I hope it comes out well. Bjorn to Fly, love this channel. Another doctor told us a few days ago the best way to get rid of diabetes is 1, fasting, 2, keto, 3, low carb, high fiber or high fat, 4, low stress, 5, exercise. That's about right. It's so weird that what's the number one danger in your body in terms of if you can't metabolize carbs? It's eating or drinking a lot of carbs. And it's frustrating that the ADA and some other standards communities say, well, go ahead and eat 200, 300 or more carbs per day, knowing that by definition, your body can't take that. So number 3, I think, is the most important. I will, again, let you know that my typical patient now is coming in from the YouTube channel, and I used to see people that were at a very basic level of information. Now, over half of my patients coming in now have already lost 30 pounds. They know this stuff fairly well. And routinely, the way they lost that 30 pounds, as in all of them but one over the past few months, and there have been dozens, they did 2 things. They went low carb, and then they closed that eating window. In other words, instead of eating from 7 a.m. till 10 p.m., they basically skipped breakfast. And most people call that intermittent fasting, but you're closing the eating window. It's called TRE, time restricted eating. And they'll eat their first meal at noon and their last meal at like 6 o'clock. Speaking of fasting, when somebody gets that far, I do encourage them to add extended fasting. And unfortunately, I haven't had a lot of takers on that. Okay, Erland FR. Don't worry about the technology. Your videos are great. Being low tech enhances your credibility. I fear that as your videos get more slick, your focusing manner and believability will suffer. I fear that as well. It's a good point, Erland. Thank you. Bart, another excellent job. Thank you, guys. And we got 10 more minutes if anybody else has anything else. Bad beat. I saw a meta study that showed pitavastatin was worse than the statins at causing new onset diabetes. Bad beat, I'd love to see, I would love to see that citation. Again, thank you very much for your interest, folks, and we'll talk to you guys later. Now, let me see if I can turn this off.